And thanks guys for proposing this topic. I was a little overwhelmed at first to try to fit sedation and ICU in 20 minutes, but here it is, and I'll just jump right in. I have no disclosures to report. So this is Dave. Well, not Dave, it's a stock photo from the internet, but the story is real. It's a 41-year-old, otherwise healthy male. He presented to a small community hospital, shortness of breath. So he developed pneumonia. He presented with shortness of breath, was diagnosed with pneumonia, developed septic shock, ARDS, continued to worsen over the next few days, empyema, sinusitis. He suffered from chronic cervical pain at home, and so was opioid dependent. So in the ICU, he underwent opioid withdrawal and required heavy doses of propofol, benzodiazepines, paralytics to control his tachycardia and asynchrony with the ventilator. 3 weeks later, he was extubated. So by all accounts, this would be a success. But this is where Dave's problems actually began. He went home and with extreme muscle wasting and difficulty walking for years, he had bizarre dreams, agitation, and daytime fatigue that limited his rehabilitation. 8 years after this admission, he was still unable to drive. So a version of this story we commonly see in ICUs, and it's one with these complex illnesses, competing physiological goals. And as this story highlights, the need for this very essential tool for the intensivists, sedation and analgesia, to manage pain, agitation, and delirium in these patients. So this is actually a digital illustration, despite its more Renaissance-like appearance. It's from an online art archive, and it's titled "Let Him Sleep." You have the god of sleep on the right, Thanatos, the god of death on the left there in the back. And they are obviously hovering over this subject. There's an interesting analogy that comes up repeatedly in the anesthesia literature, and a particularly interesting article that explores the interface between anesthesia, sleep, and death. The authors point out that the terms sleep and anesthesia are frequently used interchangeably, as when a patient is told by the anesthesiologist, "I will now put you to sleep," with his anesthetics, or we put a beloved pet to sleep. So we know that I think natural sleep, we can all agree that natural sleep and hypnosis of general anesthesia do share some common behavioral characteristics: depression of consciousness and awareness of the environment, amnesia, immobility. So, and on a neurophysiological level, you have this breakdown of communication of the brain. So historically and in current times, these concepts are interconnected. So anesthesia, sedation, analgesia, they're everyday but very powerful tools for the intensivist. We'll talk briefly about when and how to use these tools to treat commonly seen symptoms in the ICU, and how these tools and anesthesia can shape a patient's experience in the ICU and sometimes lead to long-lasting and devastating effects. So the analogy that we just discussed, of course, doesn't apply really to modern medicine, given our advances in airway management, cardiovascular management, but it's not entirely inaccurate. Without an adept anesthesiologist or intensivist, a patient may, in fact, die when being put to sleep. But it's still, regardless, not really a practical one. So on a practical level, and as a general principle of sedation in the ICU, the goal of anesthetics, sedatives, analgesia, is to provide comfort from pain, agitation, and delirium, and safety in this very artificial space that is the ICU bed, where those complex illnesses and competing physiological goals coexist. So in addition to being unpleasant and often disturbing to patients, these symptoms can lead to increased endogenous catecholamines, stress factors, increased oxygen consumption, hypermetabolism, and even immunosuppression. Unfortunately, the majority of patients in ICUs do experience pain, and it is the most commonly recalled experience from ICU survivors. Significant pains leads to sleep deprivation, exacerbates these other two symptoms, agitation and delirium. And furthermore, we know that significant pain is associated with higher incidence of post-ICU syndrome and post-traumatic stress disorder, topics we will revisit shortly. So the last and likely most complex aspect of pain, agitation, and delirium, PAD, the D, is of course delirium. And I'm happy that Dr. Urfi went into this a little bit and highlighted the fact that really it is a diagnosis of exclusion, and we need to be performing very detailed neurologic exams on patients who we suspect delirium in. And I do have mixed feelings as a neurologist about this, the definition of delirium, which is acute brain dysfunction. As Dr. Urfi mentioned, localization of the lesion is everything for a neurologist, and saying that delirium is localized to the entire brain is not exactly satisfying to me as a neurologist. But there it is. That is the term that is used. So acute brain dysfunction or delirium, it's a condition that it entails a change in level of alertness, occurs over a few days, so it's not over an extended time. It fluctuates, and it is also, in addition to change in level of alertness, level of cognition. We know that it occurs in up to 80% of patients, and it is in the ICU, and it's underdiagnosed. Short-term delirium is associated with many adverse outcomes: increased mortality, increased length of stay, increased time on the ventilator, costs, death, and other less examined metrics such as unplanned extubations or failure of planned extubations. Long-term, it's also associated with a higher chance of dying. And as we will see, delirium is associated with significant psychological and psychosocial adversities, including depression, long-term cognitive impairment, and again, post-intensive care syndrome and post-traumatic stress disorder. And these obviously, as you can imagine, can affect many core aspects of a person's life: jobs, marriage, other interpersonal relationships. For many years, particularly the last 20 years, there's been a growing body of international literature addressing the management of pain, delirium, analgesia, sedation. In 2013, the clinical practice guidelines of pain, agitation, and delirium were published, and at the time they were the most comprehensive critical care guidelines seen. These were more integrated, more interdisciplinary, and more evidence-based than there had been until that time. This was a massive effort put together by the ACCM and the SCCM jointly. And they created a multidisciplinary, multinational task force to revise the prior guidelines that were almost 10 years old at that time. In 2018, again, joint efforts. The acronym was expanded from PAD, pain, agitation, delirium, to include I and S for immobility and sleep. And these were an update to the 2013 guidelines. So these guidelines were developed to provide an evidence-based roadmap for physicians to better manage pain, agitation, and delirium in critically ill patients. So where are we and where are we going? Since then, like I said, newer publications have linked this care bundle to other evidence-based critical care interventions, such as spontaneous breathing trials, early mobility, ICU sleep hygiene. Together, these interventions can make a significant difference in patient outcomes and costs of care. So the PAD guidelines include strong recommendations for the use of these valid and reliable assessment tools that we've heard about, the RAS score, CAM-ICU. I think most people are familiar with these. and for detecting pain over and under sedation, delirium. But rather than making specific recommendations as to which drugs to use over other, they focus on the process of assessment and treatment and prevention. So we know that when prolonged, continuous deep sedation is associated with all those adverse outcomes that we've discussed. Not surprisingly, though, under treatment of pain, agitation, or delirium can lead to a lot of the same complications. And so the PAD guidelines have strong recommendations for treating pain first, before administering sedatives, and for maintaining a light level of sedation so a patient can interact meaningfully with the ICU, with their nurses, with their family, without agitation, and it does so by recommending non-pharmacologic and pharmacologic strategies. And in fact, there's a consortium of several critical care societies that publishes a Choose Wisely top 5 list, and this light level of sedation is one of their top 5 recommendations. As I mentioned, they do not give specific medication recommendations, except in one instance that has already been brought up a few times until now, which is benzodiazepines. And essentially, when you don't need it, don't use it is the take-home message, as it is the one that is associated with the highest level of adverse outcomes. Okay, here we go. Just click it. Okay. Hope it works.
For 3 weeks, I was held in a room. If I tried to get away, they would tie me to the bed. I couldn't eat, I could barely sleep, and I couldn't speak. Groups of people would come into the room and look at me and talk about me and sometimes undress me. I was shot full of drugs. I was too weak to move. I couldn't see my body, but I had been cut nearly in half. There was insects on the walls and ceiling. I was in a boat in the bottom of an underground waterway. I was in a deep well. I was tethered to the ground by rubber tubes attached to my genitals. I was in a space pod. I was on a raft, in a library, in a conference room, in a fly-by-night health clinic. I was in the Arctic. I was in the desert. They were trying to kill me. They would try to get me into a room separate from everyone else or wait till late at night. I had found out about their secret pornography ring. I tried to tell my partner about this in hushed tones because I didn't want them to hear me and redouble their efforts. Where was I? They asked me this every day, and I didn't know the answer. I was in the intensive care unit, the ICU of one of the best hospitals in the world, where doctors and nurses were using the most current medical technologies and know-how to save my life. A few months later, after I'd gotten home from the hospital, I went to see the surgeon for a checkup. And I told him about these terrible memories and the resulting diagnosis of PTSD. He said, "PTS what?" People don't generally remember anything from the ICU. Why then was I having nightmares and flashbacks and sleeplessness? Was it because I was weak? Did I lack resilience? Was I too sensitive? Was I crazy? Why was it so hard to do the things in my life that previously had been fairly easy? Why couldn't I seem to move forward? And why wasn't I perfect the way the surgeon said I would be when I recovered physically? What had happened to me in the hospital They saved my life, and for this, I am deeply grateful. But life after this ICU experience was extraordinarily difficult.
It goes on to describe how difficult it was to return to her life as an artist. Initially, too weak to draw even stick figures. But eventually she was able to create these images from her memory and recollection of her ICU experience. So we know that our patients are suffering long after they leave the ICU. The SCCM, in addition to launching the guidelines, the PAD guidelines, care bundles, also created a task force to assess and address the long-term consequences of critical illness and intensive care admission. The term post-intensive care syndrome was born to describe the physical, psychological, and mental effects long-term after an ICU stay. And the effects on ICU survivors are so broad and so profound that the term post-intensive care syndrome-family was also created to address the effects on family members of ICU survivors or those who died in the ICU. And we know that up to 30% of family members can develop anxiety and depression. So we now recognize post-intensive care syndrome as a public health burden. The cognitive impairment of PICS has been reported to occur in more than 25% of patients, up to 3/4 of ICU survivors. The psychological disability in over 60% in the form of depression, anxiety, and again, these syndromes. This is a subclassification of the physical impairments that can occur after an intensive care admission, ICU AW, ICU acquired weakness. And you can see the first group, the ones in the Venn diagram in the circle, critical illness polyneuropathy, critical illness neuromyopathy, critical illness myopathy, are those that have are with weakness, but also with electrophysiologic and histopathologic abnormalities. And then you have that outside square group where you have the same symptoms but normal diagnostic studies. So if you recall Dave from the first slide, who had significant difficulty walking, and then years later after his ICU admission still couldn't drive. And then the patient we just heard from who had difficulty returning to her life as well as an artist. And next we'll hear, they both had severe forms of ICU acquired weakness, and we'll hear about Dr. Allison Clay, a pulmonologist, who after each intubation in the intensive care unit could not independently go up to the 4 steps to her front porch. So I just mentioned Dr. Allison Clay. She spoke a few years ago at the SCCM annual meeting about her experiences, and she describes in detail the difficult and sometimes terrifying process of being intubated, and how things changed when a colleague of hers said to the team, hey, why don't you pre-medicate her prior to laying her flat, since she was keen enough to observe that it was harder for her to breathe laying flat. And she describes her ICU experience and how at one point she became so agitated and frantically self-extubated when she vomited in her mouth while restrained and unable to get the attention of the nurses. For a portion of her talk, she also recounts how it took her 3 years to be able to run 30 minutes on the treadmill. And then after her next ICU stay, she again had trouble going up those 4 steps to her front door. So the press and the lay public, they laid this problem bare, and they have reason for concern, as these stories demonstrate. And the largely undiscussed or uncovered topic of post-intensive care syndrome and PTSD in the daily work of the intensivist. But there is a lot of work being done to address the care gaps in ICUs around PAD management, early mobility, minimizing sleep disruption, and liberalizing from mechanical ventilation, all of which can combat the possibility that our patients go home to this potentially extraordinarily difficult life, and we work so hard to save them in the ICU. So we know that the assessment and treatment of PAD represents the largest care gap, despite extensive literature attempting to translate the guidelines to bedside implementation. Nursing engagement remains a critical piece in the success of PAD management, pain, agitation, and delirium, as does communication among members of the healthcare team. There was a study from Johns Hopkins University where they ended up employing the methods that they used to improve the compliance with PAD management, and that included a complex decision support software, automated task list, barcode medication administration. This was to a complex nurse-managed PAD protocol, and they found high adherence with it. One of the landmark studies that was just published in 2017 by the ICU Liberation Collaborative showed that they were able to implement the PAD guidelines in many community hospitals by linking it to the widely recognized ABCDEF bundle. So there's light at the end of this, and hopefully headlines like this will dominate over those we saw earlier. The ICU Recovery Center at Vanderbilt University is likely the most comprehensive of its kind. It opened in 2012, and it's led by Dr. Wes Ellie, who some of you may know developed the spontaneous breathing trial and the CAM-ICU scale. So it's dedicated to the recovery of ICU survivors and addresses those physical, mental, psychological impairments that we've discussed after ICU admission. Just as importantly, it's a leading research center. As you can see, these are some of the trials that are ongoing, from determining if there are oxygen levels that worsen or lead to delirium, to placebo-controlled trials of what medication may be able to prevent delirium. So it's a great resource, not just for patients, and I encourage you guys to check out their site. So I want to leave you with this last quote and challenge you to continue to frame or to reframe the way you see your role in providing care in the ICU, and to redefine success as not ending with survival. Ms. Andrews, a patient you saw in the video, goes on later to point out that there is some resistance from clinicians to hear some of these stories. And you may have heard yourself or colleagues say we saved their lives and they're still complaining. I'm paraphrasing. She uses an expletive that I left out. So all the stories you heard today would be viewed as successes because the patient survived. And that's not something to be minimized. But perhaps we, in particular, the inpatient provider, the intensivist, nurses, can start to see our role as extending beyond that and instead into the well-being of our patients once they return to their lives, so that they are truly, we are truly helping improve their health, self-worth, and personal dignity. Thank you.